Okay, we're going to continue this morning's program, and this is Paradigm Change session number 2, Early Diagnosis of Premature Ovarian Senescence, Offering Women More and Better Reproductive Options. And our first speaker this morning is Dr. Vitaly Kushnir from the CHR, who will be delivering his talk on risk screening algorithm for young women to detect premature ovarian senescence at younger ages. Vitaly.
Okay, thank you, and welcome back from the break. So I have one disclosure here. I do have some pending patents related to anti-Müllerian hormone. And I'll start off this talk by echoing what Dr. Seifer said in the last session, and that is about family planning. So what is family planning? Well, most family planning fellowships, at least in the United States, focus on the first 3 points: contraception, sterilization, and abortion services. They really don't teach their trainees to discuss or address family building with patients, and this is an overlooked issue, as Dr. Seifer pointed out. We know that family planning works. This is data from South Korea, and we can see here that excuse me, as contraception use has increased, we can see that abortions have dropped and total fertility rate in the population has dropped. And you can see data like this from all over the world. This is just a very nice slide that I found. This is US data, and we can see that over the past 40 years, the age of first-time mothers has increased by approximately 4 to 5 years, and as has the age of all mothers. We can also see that in the second slide there that the teen pregnancy rates have abruptly declined, as have birth to women in their 20s, and at the same time, women who are in their 30s and even in their 40s are having more children today. So that puts increasing number of women into this danger zone where fertility begins to decline when they're just trying to start their families. Physiologically, the fertility declines and miscarriages go up. But that's just for the average patient. What about the 10% of patients who have premature ovarian aging? Those women are at an increased risk even earlier, and some of them will go on to develop premature ovarian failure. So this is becoming more and more of an issue to identify these women early on in their reproductive lifespan, to give them options to either preserve their fertility or maybe consider having children earlier. We've certainly seen this within our program at the CHR. You can see that the age of newly presenting infertile patients to our program has steadily increased over the past decade. And you can see that the ovarian reserve of our patients has steadily decreased. Now, of course, we specialize in this area, and we're seeing probably the tip of the pyramid, but I think many of you that I've spoken to at the conference are seeing the same things in your practice, maybe not to such a large degree. We know that diminished ovarian reserve is one of the most difficult problems that we encounter in reproductive medicine and ART. This is data from the CDC, and you can see that it's actually one of the most common diagnoses that women have now going through ART. It's second behind male factor. And I would argue that it may even be more common than this, because some of these patients with unknown factors or multiple factors will actually have diminished ovarian reserve if they're more carefully studied. And what we see here is that our ability to help these patients is quite limited. Their live birth rates are by far the lowest of any other diagnosis. So identifying these patients early on would really be a huge benefit to them, because if they develop infertility and they end up in our care later on, there's limited options that we have. We've seen this slide, so I won't dwell on it, but ovarian reserve declines over the reproductive lifespan, and we have tests that can tell us about the growing follicle pool. Let me go back. The anti-Müllerian hormone can be reflective of the growing follicles. We don't have great tests that tell us about the primordial pool yet. We can infer about it based on age, but obviously it would be helpful to have a test that looks at that. And we have a number of clinically available tests that are used in everyday practice that allow us to assess ovarian reserve. And the most useful are probably here on the slide: anti-Müllerian hormone, as we've spoken about at this conference, FSH levels, antral follicle counts, and other tests. So as we think about developing algorithms, these are tests that could be incorporated into such algorithms. But I'll talk about other tests and other things that we can incorporate into an algorithm to help us identify women who are at risk early on. We've seen this slide several times through the conference, and the way that AMH and FSH interact is very important, and also AMH's ability to block recruitment from the primordial pool is very important. And this has now become a modern classic. We know that women have peak fertility when they're in their mid-20s, and their ovarian reserve is at its peak then as well. And from there on, the ovarian reserve here, measured by anti-Müllerian hormone, declines. Now, what's important is clinically we can use this kind of a normogram to identify women who have diminished ovarian reserve because they fall 1 or 2 standard deviations below their age normal range. We can also identify women up here who have abnormally high ovarian reserve for their age as having polycystic ovaries potentially. So this is AMH really gives us a very good insight into what's happening with the ovary. Our practice for a number of years has used a normogram like this that incorporates age, follicle-stimulating hormone levels, and anti-Müllerian hormone levels to determine women who have age-specific diminished ovarian reserve. Those are obviously obvious things where we can start. There are a number of medical conditions that are associated with abnormal ovarian reserve parameters, and they broadly fall into these disease categories: immunological problems, endocrine problems, genetic abnormalities, iatrogenic insult to the ovary like chemotherapy, as we've spoken about, certain inborn metabolic disorders, and certain gynecological problems. For example, endometriosis that invades the ovary. When we see patients with these things, we should be thinking about their ovarian reserve and their fertility potential. We also know that there are important racial and ethnic differences between that affect the reproductive aging, and there are a variety of genetic factors and environmental factors that have been identified, and this is a nice review by Dr. Seifer and Dr. Tal that has looked at this. And so I'll address some of the issues in this. We see that in general, Caucasian women tend to have the highest ovarian reserve throughout the reproductive lifespan in comparison, for example, to African American and Asian women, and Hispanic women. It's been suggested that African American women actually seem to age their ovaries at a bit slower rate than Caucasian women, though, even though they started at a lower baseline. We know that BMI is an important factor in ovarian reserve. Obese women seem to have lower age-specific anti-Müllerian hormone levels. We know that vitamin D has an important role in regulation of ovarian reserve. And here we're looking at FSH levels, but what we see is that women who have vitamin D deficiency seem to have relatively elevated FSH levels and therefore relatively low ovarian reserve. We also know that androgens are very important in ovarian reserve, and this is a nice paper that looks at androgen levels throughout the lifespan. This is not from me, this is my uncle actually, where you can see that the DHEA levels, androstenedione levels, and testosterone levels are actually at their peak in women who are at peak fertility in their mid-20s, and as they approach menopause, you can see a decrease in all of those levels. It's not as obvious here because of the scale, but they all decline. And our group with Dr. Gleicher has demonstrated that both women who have physiologic diminished ovarian reserve, as well as those who have premature ovarian aging will have lower androgen levels for their age. So our group has come to view the ovaries and the adrenals working as a single unit almost, where you have women here with normal reproductive potential, who have normal androgen production from their adrenals and their ovaries, normal follicular reserve. And when you move in this direction, particularly women who have abnormally high ovarian reserve, they'll have a polycystic phenotype, but they may also have overly active adrenals where they have overproduction of androgens. Whereas the mirror condition down here, where you have premature ovarian aging or women who have premature ovarian failure, they will have abnormally decreased androgen production from their ovaries and their adrenals. Often they will have abnormally low ovarian reserve. And it's been suggested that we might be able to push some of these patients back up in this direction with supplementation of androgens. We've also recently found that certain autoimmune issues can predispose women to aging their ovaries faster than normal. And this is a nice study from Dr. Vega, who did this work with us, where he showed that the presence of antiphospholipid antibodies seem to confer a higher risk for diminished ovarian reserve. And we've heard a lot today about the Fragile X in particular, but what I'd like to focus your attention on here is that the X chromosome is really a crossroads of immunology and ovarian function, with many genes that control both processes present there. I won't dwell too much on this because it was covered by Dr. By the prior talks, but we know that women who have premutation FMR1 repeats will have a higher risk for developing premature ovarian failure. And our group has also studied women who have typical range mutations and shown that there's some phenotypes there as well. This is a classic study that showed that women who have between 80 to 99 repeats on CGG repeats have the highest risk for developing ovarian failure. In this study from Gleicher et al. In 2009, they showed that in infertile patients, there is an increased prevalence of patients who have these low repeats, where around 20, there's a big spike up in the number of patients that we see in our infertility clinics. And we've since looked within our egg donors, and this data was partially presented before. What we found is that when you move in either direction from the normal, where you have the 30 and 30, as you move either up or down in either direction, what you generally see is a decrease in the anti-Müllerian hormone levels. And we've seen this longitudinal data from our egg donors, where we followed them out for about 4 years and shown that those donors that have low repeats will seem to age their ovaries faster. So this gene seems to be potentially an important part of the algorithm that we can ultimately envision. And we've also shown that women who undergo IVF who have low repeats seem to have lower live birth and pregnancy rates even when they go through IVF. So putting all of this together, our group has proposed 2 different algorithms that might make sense for different groups of patients. This algorithm is aimed at women who have a predisposition to premature ovarian aging, whether it's based on their medical history or family history or genetic abnormalities, etc. If these women can potentially be screened via this kind of algorithm, and if they're found to be at risk, we have options now for them, which includes fertility preservation. They can also be monitored with serial anti-Müllerian hormone levels, and if it's really dropping off very quickly, then maybe that would trigger us to act sooner rather than later. We've also come up with a proposal to offer this kind of screening to a more broad patient population of young women who are coming in for family planning. At minimum, they should be counseled and questioned about what is their reproductive desire, long-term reproductive plan, and what is their long-term reproductive potential. And some women can be offered testing of age-specific AMH or some of these genetic markers that we discussed, for example. If they're found to be at risk, we have fertility preservation options. We have the option to give them non-hormonal contraceptives, which would allow us to monitor their ovarian reserve longitudinally. And so I think that this is an emerging area, and the key points are here. Premature ovarian senescence is common and compromises fertility. Identification of women who are at risk is possible through various screening algorithms. Family planning visit is the appropriate setting for such screening. And the algorithm that I just outlined to you may include a variety of different points, but the most obvious would be the medical and family history, race, BMI, some hormone levels, including anti-Müllerian hormone, potentially FSH and estradiol levels, some genetic markers like the FMR1 gene, for example, and some other things like vitamin D or potentially immune tests. And today, women who are at risk have a number of options, including fertility preservation. Thank you.